Idiopathic orbital inflammatory syndrome, IOIS, also known as orbital pseudotumor, is a non-infectious inflammatory condition of the orbit, the area surrounding the eye, without a known cause. It can affect various orbital structures, including muscles, fat, and lacrimal glands, and often presents with acute symptoms such as pain around the eye or with eye movement, proptosis, bulging of the eye, diplopia, double vision, swelling of the eyelids, redness. The diagnosis is typically one of exclusion after ruling out other causes such as infection, malignancy, or autoimmune conditions. Imaging, especially MRI or CT scans, helps in identifying the inflammation. Treatment is usually with corticosteroids, which can effectively reduce inflammation, though recurrence is possible. In some resistant cases, immunosuppressants or radiotherapy may be considered. Idiopathic orbital inflammatory syndrome, IOIS, also known as orbital pseudotumor, is a rare, nonspecific orbital inflammation that typically occurs in the absence of an identifiable cause, such as infection, trauma, or systemic disease. It can affect any structure within the orbit, including the extraocular muscles, lacrimal gland, optic nerve, and orbital fat. Clinical presentation, pain, the most common symptom, often severe, and worsens with eye movement. Proptosis, unilateral eye bulging is common, but bilateral involvement can occur, especially in children. Diplopia, double vision, results from restricted movement due to involvement of the extraocular muscles. Periorbital edema and erythema, swelling and redness around the eye. Vision changes, blurred vision, or decreased visual acuity can occur, especially if the optic nerve is involved. Chemosis, swelling of the conjunctiva, white of the eye, is also possible. Systemic symptoms, fever, malaise, and occasionally nausea or vomiting, especially in severe cases. Classification of IOIS. IOIS can affect various structures in the orbit, leading to different subtypes based on the primary site of inflammation. 1. Anterior, periscleritis, involves the anterior orbital tissues, including the sclera. 2. Myositis, involves the extraocular muscles, leading to pain with movement and restricted motility. 3. Lacrimal gland inflammation, dacryoadenitis, results in pain and swelling over the lateral aspect of the orbit. 4. Optic neuritis, inflammation around the optic nerve, leading to visual impairment. 5. Diffuse IOIS, involves multiple structures in the orbit. Diagnosis, clinical examination, involves evaluating eye movement, bulging, and any inflammatory signs. Imaging, MRI or CT scans of the orbit are crucial for diagnosis. Imaging shows diffuse or localized orbital inflammation, sometimes with mass-like effects, but without evidence of a tumor. MRE is preferred, showing soft tissue involvement and inflammation. CT scans may reveal thickened extraocular muscles, lacrimal gland swelling, or diffuse inflammation. Biopsy. In cases where malignancy or infection cannot be ruled out, a biopsy may be performed to confirm the diagnosis and exclude other causes like lymphoma or sarcoidosis. Blood tests. While no specific lab test confirms IOIS, basic blood work may help rule out systemic diseases like thyroid eye disease or vasculitis. Differential diagnosis. Thyroid eye disease, Graves' orbitopathy, can present similarly with proptosis and muscle involvement, but is associated with hyperthyroidism and has distinct imaging features. Orbital cellulitis, an infectious condition that presents with similar symptoms but often involves fever, leukocytosis, and positive cultures. Lymphoma can mimic IOIS, especially in older patients. Biopsy is often necessary to rule this out. Sarcoidosis can present with orbital inflammation and must be considered, especially if systemic symptoms are present. Treatment: corticosteroids. High-dose oral or intravenous corticosteroids are the first-line treatment, leading to rapid symptom improvement. Prednisone is commonly used, and the response is often dramatic within 48 hours. Steroid-sparing agents. In cases of recurrent or steroid-dependent disease, immunosuppressive agents like methotrexate, azathioprine, or mycophenolate mofetil can be used to maintain long-term control and reduce steroid side effects. Radiation therapy. In refractory cases or those unresponsive to steroids, low-dose radiation may be effective. Surgical decompression. Rarely required, but may be considered if there is significant optic nerve compression or for biopsy purposes. Prognosis. Most patients respond well to steroids, with a marked reduction in pain and swelling. Recurrences are common, and long-term follow-up is often necessary. Delayed or untreated cases, especially involving the optic nerve, can lead to permanent vision loss. IOS remains a diagnosis of exclusion, and careful evaluation is needed to ensure no underlying systemic or neoplastic cause. Early intervention with corticosteroids can prevent complications like optic neuropathy and vision loss. Idiopathic orbital inflammatory syndrome, IOIS, is generally considered an immune-mediated disorder, but its exact classification as autoimmune or autoinflammatory remains debated. It shares features of both categories. 1. Autoimmune features. IOIS often responds to immunosuppressive treatments, such as corticosteroids, suggesting an immune system dysregulation where the body mounts an inappropriate immune response against its own tissues. Some forms of IOIS involve B and T cell mediated immunity, typical of autoimmune diseases. 2. Autoinflammatory features. The disorder also involves nonspecific inflammation of the orbit without any detectable systemic autoimmune disease or a specific autoantigen, which is more characteristic of autoinflammatory diseases. In autoinflammatory diseases, the innate immune system plays a more central role, often without the involvement of autoantibodies or autoreactive T cells. While the exact cause remains unknown, IOAS appears to be a localized immune response triggered by an unknown stimulus. It doesn't clearly fit into the classic definitions of either autoimmune or autoinflammatory diseases, but it is more often treated like an autoimmune disorder due to the strong response to immunosuppressive therapy. Hereditary factors. Idiopathic orbital inflammatory syndrome, IOIS, is not typically considered a hereditary condition. There is no strong evidence to suggest that it runs in families or that specific genetic mutations predispose individuals to develop the disease. However, like many immune-mediated disorders, a genetic predisposition for immune dysregulation might play a role, but this has not been definitively proven in IOIS. Research on hereditary factors in IOIS is limited, and more genetic studies are needed to clarify this aspect. Epidemiology and prevalence. IOIS is a relatively rare condition, and its true prevalence is difficult to establish because it is a diagnosis of exclusion. However, based on available reports, prevalence estimated to affect around 6 per 1 million people per year. It is an uncommon cause of orbital disease, far less common than thyroid eye disease or orbital cellulitis. Age. IOS can occur at any age, but is most commonly diagnosed in adults, particularly in the 30 to 60-year age range. It can occur in children, but pediatric cases are rarer and often involve bilateral orbital inflammation. Gender. There is a slight female predominance in many studies, but the gender distribution is generally close to equal. Ethnic variations. IOIS appears to affect individuals of all ethnic backgrounds, but there is limited data on whether certain ethnic groups are more or less susceptible. Most studies have been conducted in Western populations, so the disease's behavior in different ethnic groups is not well documented. Ethnic and geographic variations. While IOIS has been reported globally, there may be regional variations in the presentation, diagnosis, and management of the disease due to differences in healthcare access, diagnostic capabilities, and awareness among clinicians. However, the literature does not suggest a clear ethnic or geographic predilection. Some reports suggest that in Asian populations, IOS might present with slightly different clinical features, such as more frequent lacrimal gland involvement. This, however, may be attributed to diagnostic practices rather than intrinsic ethnic differences. Summary of prevalence and ethnic variations. Global occurrence affects people of all ethnicities, though most studies focus on Western populations. No strong hereditary link has been identified. Epidemiology, most common in middle-aged adults with a slight female predominance. Cases in children often involve both eyes. Limited evidence of ethnic variations, though some clinical differences in presentations may exist based on geographic regions. More research is needed to establish specific patterns across different ethnic groups. The management of idiopathic orbital inflammatory syndrome, IOS, has evolved, with the emphasis on early diagnosis, individualized treatment plans, and the use of steroid-sparing agents for chronic or recurrent cases. Here are the updated guidelines based on recent advances. Have 1. Initial evaluation and diagnosis. IOS remains a diagnosis of exclusion, requiring comprehensive evaluation to rule out other causes of orbital inflammation, such as infection, malignancy, thyroid eye disease, and systemic autoimmune disorders. History and physical exam, thorough examination, focusing on eye pain, proptosis, diplopia, and signs of orbital inflammation. Imaging, MRI with contrast, preferred for evaluating soft tissue involvement, showing diffuse or localized inflammation. CT scan can reveal bony involvement or extraocular muscle thickening, helping differentiate from other conditions. Laboratory tests, complete blood count, thyroid function tests, autoimmune panels, e.g. ANA, ANCA, to rule out systemic disease. Biopsy is indicated if malignancy, infection, or systemic disease is suspected, especially in recurrent or atypical cases. 2. First-line treatment, corticosteroids. High-dose corticosteroids remain the cornerstone of treatment, especially in acute cases with significant inflammation and vision-threatening involvement. Oral prednisone. Typical starting dose, POP to 1 to 1.5 milligrams per kilograms per day, often around 60 to 80 milligrams per day in adults, followed by a gradual taper over 4 to 6 weeks based on response. Rapid symptom improvement is usually seen within 48 to 72 hours. Taper slowly to prevent recurrence, often continuing a low-dose regimen, e.g. 5 to 10 milligrams per day, for several months in chronic cases. Intravenous methylprednisolone. For severe or sight-threatening cases, such as optic nerve compression, IV methylprednisolone, 1 gram per day for 3 days, followed by oral prednisone can be used. 3. Steroid-sparing agents for long-term management. Due to the potential for steroid-related side effects, e.g. osteoporosis, diabetes, hypertension, steroid-sparing immunosuppressive agents are recommended in patients with chronic or recurrent disease. Methotrexate, a commonly used first-line steroid-sparing agent. Dose 10 to 25 milligrams weekly, often in combination with folic acid to minimize side effects. Azathioprine, another effective steroid-sparing agent. Dose 1 to 3 milligrams per square day, depending on patient tolerance. Mycophenolate mofetil, useful in patients who do not tolerate methotrexate or azathioprine. Dose 500 to 1500 milligrams twice daily. Rituximab, for refractory or severe cases unresponsive to conventional immunosuppressants. Rituximab, a B-cell depleting agent, may be considered. 4. Radiation therapy. Low-dose orbital radiation can be considered in patients who fail medical therapy or have contraindications to long-term immunosuppression. Dose. Typically, 20 GBi in divided fractions is used, targeting the inflamed orbital tissues. Indicated for refractory IOIS or cases where rapid control is needed, especially if optic neuropathy is present. 5. Surgical management. Surgical intervention is generally reserved for diagnostic biopsies or in cases of severe proptosis, optic nerve compression, or lack of response to medical therapy. Orbital decompression may be required if there's significant optic nerve compression or severe proptosis threatening vision. Biopsy, always considered if malignancy or infectious causes are suspected, particularly in atypical or recurrent cases. Summer 6. Management of recurrent or chronic disease. Low-dose corticosteroids. Some patients with recurrent disease may require maintenance therapy with low-dose prednisone, e.g. 5 to 10 milligrams per day. Chronic immunosuppressive therapy. Long-term use of agents like methotrexate or azathioprine is often necessary to maintain disease control and prevent relapses. Biologic therapies. For severe resistant cases, biologics such as infliximab or rituximab can be considered, though more evidence is needed to standardize their use in IOIS. Chapter 7. Monitoring and follow-up. Regular follow-up is essential, particularly during tapering of corticosteroids or when using immunosuppressive therapy. Ophthalmologic exams monitor visual acuity, proptosis, eye motility, and any signs of optic nerve compression. Imaging. Repeat MRI or CT scans in patients with severe disease or poor response to treatment to assess the resolution of inflammation or progression of orbital involvement. Side effect monitoring. Regular blood work for patients on long-term steroids or immunosuppressive agents to monitor for side effects like liver toxicity, cytopenias, or infections. 8. Management in special populations. Children. IOIS in children often presents bilaterally and may require more aggressive management with immunosuppressive agents due to higher recurrence rates. Steroid-sparing agents like methotrexate are frequently used. Pregnancy. Corticosteroids can be used in pregnancy, but steroid-sparing agents like methotrexate and azathioprine are contraindicated. Close monitoring and dose adjustments are necessary. Conclusion. Corticosteroids are the first-line therapy for iOS, but steroid-sparing agents are increasingly being used to reduce long-term side effects and manage chronic disease. Early intervention is critical to prevent complications like optic neuropathy and vision loss. Treatment should be individualized, and multidisciplinary care involving rheumatology, ophthalmology, and radiology is often needed for complex or recurrent cases.